6:05 here. So I think Dr. Laban, just in the interest of time, we'll start our session. So I wanted to give a warm welcome to all of you who have joined us this evening. You will likely see a number of other boxes of names and square faces popping up. We do have a large session, over 50 people joining us tonight, close to 70 registered. So it's exciting to have this much interest. We are excited to have Dr. Preema Laban, who is as I check my notes for formal titles. Dr. Preema Laban is the adult psychiatrist with the reproductive mental health team at Surrey Memorial Hospital. She's joined by her colleague, Tammy Stott, who is a registered psychiatric nurse and clinician with the program. And you are finding yourself in a Zoom session this evening to learn about medication management and perinatal depression. So we're very happy to have you. I'm very excited for this evening. And Dr. Laban, I will hand over the session to you to do some screen sharing. As you're getting ready to do that, I'll just remind the audience this evening's session is going to be interactive. We really want to hear from you. We want to hear about your experiences, and Dr. Laban is really excited to hear about any cases that you may be willing to bring forward and chat about. She's got opportunities through the evening for you to interact and talk about cases and ask specific questions. So if you do want to participate in that discussion, there is a raise your hand function in chat in the Zoom features. So please feel free to raise your hand if you want to engage in some of those discussions. There's also the chat functionality, so please feel free to enter in your questions or something that you might want to discuss as part of the conversation this evening. Feel free to enter that into the chat as well. If you do raise your hand, or if we call on your name to chat, we'll unmute you so that you could have that conversation with Dr. Laban, and Tammy, if she joins in as well. I'm going to make sure that everybody has the opportunity to speak who wishes to participate in that way. And Dr. Laban, over to you for now.
Thank you so much, April. Good evening, everyone. I'm Dr. Laban. I'm the psychiatrist at the Repro program in Surrey, and I have with me tonight Tammy Stott, who is our clinician in the program and in charge of our therapy program. So it's a real pleasure for me to see so many people having an interest in perinatal depression and also in wanting to give up their time. I'm mindful about how busy all of you are in your practices, and I think it's really wonderful to see that you're sparing this time to have this discussion about perinatal depression, because I think it's very important to me, as well as to our program. So we have about 100 referrals a month from family doctors in our area. So I know that this is something that's very, very important in all your practices. I also want to thank April for the organization, everyone in her team, as well as Dr. Hussein, who referred us to do this talk with you guys tonight, and the AMHSUing project that's happening to help connect psychiatry and family doctors, just to help us improve on our communication and just so that we're all on the same page with management of patients. So tonight we're talking about perinatal depression, and I've titled it Perinatal Depression Prescribing, a Conundrum, because that is really what it is. Even from a psychiatry's perspective, it's a complex process. And in many ways, we know that medication and pregnancy are not really well suited, and the best for any pregnancy is no medication. So it's a real conundrum for us in terms of determining how to manage patients with medication in pregnancy. Well, I'm going to try and go down in the slides. There you go. So this slide is a very nice depiction of perinatal depression, or what a postpartum depressed mom thinks about. These drawings and cartoons were done as a project by someone who had postpartum depression and who wanted to convey in pictures and words what happens when someone is depressed. And as you can see, this is a mom who's breastfeeding with a friend who's not pregnant and maybe possibly single, who's busy reading a book and looks very smart and dressed up and thinks that it's the best time in her life because she's a mom. And of course, these are the thoughts that are going through the mom's mind, which are all of the concerns that she has. A lot of them are regretful, and a lot of them are scary. The thoughts about finding her baby dead in her crib, having the baby fly out of the car seat into a ditch, dropping the baby onto the cement or down the stairs, off the balcony, letting the stroller go down the road. Those are the commonest intrusive thoughts we see in our program. And as you can imagine, how scary this is for a mom to think that about her newborn, but also how scary it is for her to say this to someone else, especially a healthcare professional, as well as her partner, who is the baby's dad, and family members who might judge her for the thoughts that she has. So this is very much a problem of secrecy as well with regard to the intrusive thoughts. Like, moms don't like to tell anyone what's happening, which makes the diagnosis of perinatal depression far more difficult. So tonight we're going to talk about this psychiatric mobility in the perinatal spectrum, because medication management starts with diagnosis. So properly diagnosing a major depression is what is the sort of the starting line for discussing medication management. And then we will look together at a rationale for treating perinatal depression. Like, should we actually do something about perinatal depression and why? And then we will go through the principles for initiating common antidepressants in pregnancy and the postnatal period, talk about some common antidepressants and the risks and benefits to them, and what to do when you have someone in your practice who falls pregnant on psychiatric medication. So this is the first poll question, and April's going to help me with this. So 60% of women have their first episode of major depression in the postpartum period. Is that true or false?
Dr. Laban, I'll need you to just stop your screen sharing and I will launch the poll for you.
Oh, yes, that's fine. Sorry, there we go.
That's okay. Perfect. Oh, it says I am logged in from another device. Dr. Laban, are you able to launch the poll? Because I think
I can, April. I don't know if I. Here, I'll launch it.
Oh, because I see. Yeah, we're both locked as SND. Yeah. So it's slide 4. That's the poll.
We're at 30 participants.
All right. Okay. I'm going to end that, and then I'm just going to share results, right? Okay. Here we go. And then I need to go back to screen sharing. This is going to be complicated. So you have to stop sharing it on your side. And then I can go back.
There we go.
Sorry. Here we go. And let me share the screen. And go up again. Can everybody see the screen with the results?
Yeah.
Yes. Okay. So 80% of you were right. 80% of you were right, and that's really good to see. So this is very important because the incidence of major depression in the general population is 10 to 20%. And we know probably the percentage of women in the population is slightly higher than men in the population, and 60% of women who present with their first episode of major depression do so in the postpartum period. Okay. Let's go back to the slideshow. All right, so what is the psychiatric morbidity in the perinatal spectrum that we see? So we know that generalized anxiety disorder occurs in about 10-12% of the general population. In pregnancy, it's slightly higher. There's comorbidity usually with OCD, and sometimes we see patients who have obsessive compulsive personality traits or have generalized anxiety disorder. But you will probably see patients in your practice who have generalized anxiety disorder. That's the disorder that has excessive worry about everything and anything. And you would see escalation of that in the pregnancy, and it's usually associated with panic attacks and changes in sleep. That's how they will present to you. And it's very important for you to differentiate that patient from the next two patients, who are those with situational crises, recoded relationship issues, and those with adjustment disorders who present with depression and anxiety. And the reason for that is that the management of those three disorders are different, but all present with a similar level of anxiety. So the characteristic of the generalized anxiety disorder patient is that they've probably had anxiety for most of their life. They have excessive worry about everything and anything in any situation, sometimes escalated in social situations, but usually not trigger specific. Sometimes there can be escalation when there are triggers. Situational crises or recode relationship issues is when you as the family doctor are going to see the most likely patient who is anxious and emotional and labor in pregnancy. Usually it's an unsupportive spouse, but because we live in Surrey, 60% of our patients are from an extended family situation. So there's lots of family dynamics that get into the mix in pregnancy. And so those moms get really, really anxious and stressed out by little things that occur in the home, especially postpartum, in terms of differences around childcare, interfamily dynamics between both sides of the family, a husband who doesn't fully understand what mom is going through when she's postpartum, and then relationship issues that occur with arguments and poor sort of relationship dynamics that escalate during pregnancy. With a mom who has an adjustment disorder, there's a very clear stressor that you can identify. And usually the anxiety starts immediately after the stressor, usually within 3 months of the stressor, and resolves when the stressor is resolved. And those moms usually end up with a situation that has occurred that is a stressor that would cause them to become anxious or depressed, and it's not part of their normal life phases. So, for example, if someone loses a job, the husband loses a job, if the immigration visa doesn't come in, or if they have a car accident, or if something gets stolen from their home, those are the stresses that occur that can make them have an adjustment disorder, versus someone who is anxious all the time, who has generalized anxiety, and someone who has more situational crises that develop that are usually relationship-based. So all three of those disorders can present with someone who is anxious, but also someone who is emotional, crying, and tearful. So it's very hard when you're dealing with someone, and I know because you're busy in your practices and you don't have a long time to actually figure out what this is. It's important for you to know what a major depression is, because the major depression is the patient who has a discrete episode of worsening mood or loss of interest, but most likely depressed mood, more days than not, more hours in a day for 2 weeks. And so that person is the major depression according to the DSM-5, generally. In pregnancy and postpartum, the major depression looks very different, because the depressed mom postpartum is detached, withdrawn, has escalation and intrusive thoughts, and wants to disappear or wants to run away, is not necessarily sad. The other way that the depressed mom or someone with a major depression presents postnatally is with rage. So they have irritable mood, emotional lability, and rage. So that's very different from your typical major depression, where someone has depressed sad mood, as the DSM describes it. Then you have bipolar disorder, and usually this is a difficult one because sometimes bipolar disorder presents for the first time postpartum. And so it can be a depressed episode, but usually it's a mixed episode. So they have sadness, but they sort of emotionally labile, and they sometimes can be manic, but most likely they have a mixed episode. So they are sad, but they have increased energy, agitation, not sleeping, are impulsive, and they also have some soft psychotic symptoms, like having some paranoia. So that is the spectrum of mood disorders that you would see, and anxiety disorders, because they're usually comorbid in the postpartum period that you have to differentiate from so that you can decide on medication management. Postpartum blues is a syndrome. It's not a disorder, and it occurs in about 70 to 80% of patients postpartum, all cultures, and it all has unique symptoms in different cultures. And in fact, a lot of the cultural rituals that are in most cultures, and I studied this many years ago as part of my qualification, you find it in every culture. A mom will be taken to their mom's home, and there's all these rituals where she is supported, and there are religious rituals, spiritual rituals, cleansing rituals that happen because it's so common. Some of the cleansing rituals are to prevent postpartum psychosis, which was usually presenting like a delirium-like psychosis within the first 72 hours of delivery of a baby. It is extremely rare. Postpartum psychosis is in less than 1% of the population. So it is an extremely rare psychiatric condition. It's more likely to occur where there is a strong family history of schizophrenia, or there is a past history of a psychotic episode. And it usually occurs early in the postpartum period, not later. And its symptoms are very, very clear, first-rank schizophrenia-like symptoms in an emotionally labile woman versus the person who has major depression, sadness, and difficulty feeling attached to the baby, who has these soft signs of auditory or visual hallucinations where people are talking to her and telling her, calling her name, or waking up in the night thinking she has a baby crying. That's not someone with postpartum psychosis. That's someone who has a depression, who's developing some soft psychotic symptoms and a severe depression. And then the final two categories we see in the postpartum period are trauma-related disorders, which are previous PTSD from childhood sexual trauma, usually, that present with relapses of the PTSD when they give birth to a baby, or actual birth trauma that occurs at the time of birth or previous birth trauma. And then we have a huge substance-related disorder, mood change that can occur postnatally, whether it's alcohol, opiates, or crystal meth or methamphetamines. All right, so the next question. The risk of postpartum depression increases from 10 to 15% to 25% if there is a history of postpartum depression. Is that true or false?
And Jody's going to launch the poll for you just to see if we can do this without having to stop screen sharing.
Oh, I just stopped it.
That's okay. No, that's okay.
And we have 36 respondents.
Okay. All right,
And
so you can
there's the
share the
results.
results. Yeah. And then share my screen. Go back here. All right, so 97% of you said this was true. It was a little bit of a tick of a question because it does increase, but it increases far more than 25%. It's closer to 50%. So it's a really very high risk factor for the postpartum depression. So postpartum depression is really a recurrent disorder. And we, for example, we have a mom right now in our virtual hospital that has had 3 pregnancies and has had 3 recurrent episodes of severe postpartum depression. So the incidence is closer to 50% if you've had postpartum depression before. So from a psychiatric perspective, these are the moms we would like you to kind of keep a close eye on or refer to us if you can.
Dr. Laban, there's a question in the chat. What is
Yes.
the most common substance use disorder we see related to postpartum depression? ETOH or other?
So, alcohol is probably still the commonest because it's the most sort of available substance. We do see some cannabis-related disorders, but they're usually anxiety-related disorders. There is a percentage, so the incidence of opiate use disorders and crystal meth or stimulant use disorders is around 5%, which is just slightly higher than you would get from sort of the general population. However, we have found that pregnancy itself is a real deterrent for substance use. Like I work at Maxine Wright Community Center, where we see the comorbid substance use and mentally ill patients who also have either domestic violence or transitional housing issues, and we see moms who have been struggling with crystal meth use for years suddenly stop dead the minute they find out that they're pregnant, and they stay sober throughout the pregnancy. And the same for many opiate users that end up coming to the program or going into rehab or going into a detox program. The only substance that we don't see that happening as often is moms who smoke and then moms who use alcohol. But generally with the harder drugs, the baby acts as a deterrent for them to continue their substance use. All right, so how do you identify these at-risk moms that I'm talking about that have all of these disorders? So this is the typical mom and dad with a newborn. And, when this mom comes to you, you normally do the EPDS. So both the EPDS and the G87 and PHQ-9, actually for depression, the PHQ-9 and the EPDS are regarded as significant scales to identify a mom at risk for postpartum depression. But this slide tells you that the mom at risk usually doesn't even disclose their symptoms to their partner because she can't figure out her symptoms herself. And there's a lot of mom guilt in acknowledging that she wants a break from her baby and that she wants to be able to have her own needs met so that she can be a better mom. And so it's a very difficult conversation to have with moms, and it's a very difficult conversation for them to have with their spouses or partners. And so this is a conversation that needs to happen in a pregnancy. It needs to start early on in a pregnancy, where moms get comfortable talking about how they're feeling with you, the family doctor, with their midwives, or with their partners. And by the time they get to the postpartum period, when they're not able to communicate really how they're feeling because their thoughts are all jammed up in their head with being anxious and sleep deprived and emotionally labile, they can actually reach out for help. Okay, so this is a case I want you to just talk about. So this is one of the typical cases you'll see in our program. We get about 100 referrals a month to the program, and of them, I would say probably about 20 have this kind of a picture, which is no past or family history of depression or anxiety, usually early miscarriages and 2 or 3 previous pregnancies, which starts them anxious in this current pregnancy. And there's worsening anxiety in the first trimester, and that's usually related to very practical things like having a positive pregnancy test, checking consistently if they're bleeding, waiting for the ultrasound, which only happens at like 8 weeks or so to see if there's a heartbeat, then waiting for the dating ultrasound, which increases their anxiety. And at the same time, they're nauseous, they're throwing up, and they have the memory of the previous miscarriages that are just flooding their heads. They're not sleeping well. So their anxiety worsens at that stage. And this is the mom that is most likely going to develop depression in the pregnancy itself. And in them, you see in the second trimester, which is usually supposed to be the best trimester in a pregnancy, because mom's no longer nauseous and throwing up, has a little bit more energy, is sleeping better, but is not too big and, in a lot of discomfort in the last trimester when they're not sleeping again. So here they're supposed to have the best part of their pregnancy and enjoy it. But in these moms, you start to see changes in mood, intrusive thoughts, poor sleep, lots of guilt about worrying about whether, anything that they do is affecting the baby and could cause the pregnancy to terminate. And the anxiety can be reached really irrational proportions, in terms of checking food labels, checking what they're eating, checking their pets, doing lots of rituals to make sure that there's nothing that they're doing that's going to terminate the pregnancy because they've had these losses before. So the obsessive health anxiety can get quite out of hand in the second trimester. Lots of internet researching, and unfortunately, like, social media is not the best for these moms because they end up on Facebook groups and learn all statistics about all kinds of things that can happen in pregnancy. And this moms will start to have panic attacks at night. So if a mom starts to have panic attacks at night in the second trimester, this is a mom that's going to develop depression by the third trimester and postnatal depression, because the commonest association with major depressive episode, even outside the postpartum period or pregnancy, is major depression. So where you have major depression, you look for panic disorder because they generally are comorbid conditions. So if your mom starts to have panic attacks at night in the second trimester, this is a mom that you need to keep your eye on that's possibly going to get depressed. And the important thing to understand about panic attacks is that they are not anxiety attacks. So panic attacks are spontaneous. They come out the blue. These moms are not your hyperventilating mom. These are your moms that can't get air in and have a sense of gloom and doom and generally feel that they're going to die and may have intermittent sort of chest pain. The severe panic attacks resemble like someone having an MI, and they can be rushed to hospital, and the only way they're not having an MI is because the ECG tracing is normal. But they can have very high systolics, and they can have a very high tachycardia. So that's why panic attacks are such a risk for pregnancy, because in the second trimester, if they're occurring, they're increasing the likelihood of pregnancy-related hypertension being diagnosed in a mom when it's actually just a panic attack that they're having. So we want you to, in these moms, to start to have a higher index of suspicion that they are going to have depression. All right. So this question is 5% of maternal perinatal deaths in Canada are from suicide, which occur commonly in the first month after birth. So this is all maternal deaths.
We have about half of the group responding right now.
Yeah, it's not an easy one.
No, this one's taking a little longer to choose the answer. Okay, it looks like we've trickled off, so I'll end the poll.
Okay. All right, so 58%, well, you kind of split 50-50 in this poll, I would say, because a lot of people didn't respond, and I think because the abstainers also didn't know which way to go. So again, this was a slightly, some of it is true, some of it isn't true. So 5% of maternal perinatal deaths in Canada are from suicide. I have given the paper, unfortunately, the attachment that I sent to you all the first time for the pre-reading would not have opened because it was not attached properly, but April will send it to you afterwards. The actual paper that was done for the Canadian study, which was a retrospective study that pulled all the data in Canada with regard to maternal perinatal deaths. And 5% of them are from suicide, but they don't occur in the first month after birth. They occur between 5 to 7 months after the baby is born. So that tells you that there are two peaks to postpartum depression. The first one is straight after baby is born, but the second peak to postpartum depression can occur between 5 to 7 months when the mom's already established a relationship with the baby and their postpartum depression has often not been treated. They are the ones who sometimes have postpartum rage. What is scary about this statistic, or even that study that was done, you'll see that most studies on suicide show that women use non-lethal methods to commit suicide versus men. That's in general suicide studies. But in the postpartum mom, most of these deaths are from lethal means, and the commonest is hanging. So these moms are really at risk, and this is one of the reasons why we want you to keep a close eye on a mom who has postpartum depression, because, and that's why our program also keeps a mom in the program until a year postpartum. And so this is one of the first Canadian studies that were done to give us actual Canadian statistics. We had a hint that this was the kind of incidence worldwide, but we didn't know anything about Canada. So they usually sort of have this high, there is a certain percentage of women that do attempt suicide in the first month after, but the successful suicides are 5 to 7 months after. And in fact, we had one very tragic case that happened about 2 or 3 years ago, Tammy, right? In which a psychiatric nurse, who was the mom, presented at a Fraser Health hospital in the middle of the night with her dad and her husband, and was assessed as having postpartum depression. She was referral was sent to our program. She was offered medication, and she went home with her husband and her dad and the baby. And while they were downstairs, she went upstairs to the bathroom and hung herself the same night that she was seen at the emergency room. And we have seen since then 2 more presentations at the Emerge who had a suicide the same night when they went home. All right, so why do we treat depression then? Having done that study slide, I'm sure you know that the reason we actively want to treat it is to make sure that no mom attempts suicide. Dr. Hussain, was our previous head of department, was very clear with me when I took over the Repro program, and he basically said, these are the deaths that make headlines. And these are the deaths that affect communities when moms disappear into the forest or when moms kill themselves. So this is why our program needs to be on top of all our referrals. This is why he insisted that every referral to our program has a psychiatric assessment, even if they present with mild symptoms. It's because something can go wrong quickly and suddenly, and it's not just a mom. It affects a whole community, and it affects families and children. So depression in pregnancy is associated. These are from studies that are pooled studies. Some of them are retrospective studies. Some of them have more data, evidence-based data, some less. But generally speaking, there's an increased risk of baby coming earlier if the mom is depressed. A higher incidence of low birth weight in these moms, high incidence of gestational diabetes, and perinatal death from the newborn's perinatal death. There's a long-term adverse effect on an infant's cognition, and an impact on the mother-infant relationship. And why that's so significant for psychiatry is the mother-infant relationship is the attachment relationship. And we know that many of the patients we struggle with in our practices have personality disorders. And the reason they develop personality disorders is because of attachment issues when they were babies or children. So, in terms of sort of long-term mental health in a community, the mother-infant relationship is a starting point. And so depression in pregnancy needs treatment because it's a one way that we can improve the mental health of children, reduce the mental health statistics in teenagers, and improve the quality of life of adults and prevent the cycle that we see. So now we come to the topic, which is medication management in pregnancy. And this slide says it all. It's a balancing act. It's literally balancing the risks versus the benefits. So the risks to the mom of not taking medication, if she has a depressive disorder or any other psychiatric disorder that would benefit from medication management, and the risk to the baby of her taking medication. And this is really a case-by-case sort of situation. This is not like a one-size-fits-all kind of situation. And that's a message I'm hoping to communicate today more than anything, that every patient needs to be treated as an individual, because there's so many factors involved in the decision to prescribe medication. My advice would be that when you are starting someone on medication, this is the first line that you write in your notes, that this person has got a perinatal depression or pregnancy-related depression. This is a risk-benefit ratio analysis. The risk to the mom is greater, therefore, we are prescribing medication. Because that is literally how the principle of medication management in pregnancy works. All right, so time to answer questions again. So 50% of postpartum depressive episodes can occur prior to delivery. Yes or no, or true or false?
Okay, I think we got it. Here are the results.
That's great. 70-30. Well, yeah, 70% of you are right. It can occur in the last trimester of pregnancy. So the symptoms of perinatal or postpartum depression actually start in the last trimester of pregnancy. And I'm sure you've seen that clinically, that moms start to get, so that mom that I talked about in case one is a mom that would become sort of more anxious in the second trimester, have panic attacks in the second trimester, start to develop depressive symptoms in the third trimester when it's too late to start medication, and postpartum depression usually kicks in around that point before they deliver the baby. And so you can identify the mom with postpartum depression before she delivers her baby. All right, so what are the principles that you need to be aware of when you're prescribing? And I know that most of you know that the college has come up with guidelines now on informed consent for medication management, and that we need to document in notes that we have got informed consent from the patient, which means a discussion around indications for the medication initiation, how we're going to do it, the risks and benefits of it, and adverse events associated with it. And we need to document that the patient provided informed consent when we write the prescription. So as I already said, this is the risk-benefit analysis. So you're weighing up the risk to the mom of not taking it, the risk to the infant of not taking medication, because both are at risk if they're not treated for the postpartum depression or the depression in the pregnancy. as well as the risk to the infant of prescribing the medication, and document the nature of the discussion with the mom. And I'll give you some tips on how to do it quicker. So in terms of the prescribing principles, so the BC guidelines, the Standard of Excellence guidelines from BC Women's that were put out, unfortunately, a little bit earlier than 2022. They were put out in 2016. There's no real advance on them, but the NICE guidelines that were put out in 2020 say pretty much the same thing, which is if you have a mom who has mild to moderate major depression, that mom can be managed with cognitive behavioral therapy or interpersonal therapy. So you have the option then when you're having the discussion with the mom of saying, the depression is a risk to you and a risk to your baby. We have the option of medication. Your symptoms are currently in the mild to moderate category. We can do this with cognitive behavioral therapy or interpersonal therapy. The challenge with this is that we don't really have interpersonal therapy one-to-one or cognitive behavioral therapy one-to-one available to these moms. Secondly, this would require a mom to have the time, the resources to be able to do it. And most of these moms have toddlers. They're either working or they have medical comorbidity in a pregnancy. So really, it's sometimes not that realistic for them to use it as a treatment modality on its own, especially for the mom with moderate major depression. But the mom with mild major depression, you can certainly make the attempt for them to connect to a CBT program. So all the repro programs in Fraser Health, as well as Vancouver Coastal, offer cognitive behavioral therapy in a group format. So there is a drop-in skills group in our program, and then there's also a formal 8-week cognitive behavioral therapy group, which Tammy can tell you about a little bit later on, that will help them manage their mood and anxiety with cognitive behavioral therapy. The Royal Columbian Hospital program does offer interpersonal therapy right now in a group format, and our program is developing one for start next year, because we have a psychiatrist who's going to also join Tammy in offering the IPT. So this might be more accessible to some moms. For severe major depression, you have to offer them an antidepressant and document refusal of an antidepressant. And that's a very important step for you to do, because the guidelines say that someone with severe major depressive disorder has to be managed with an antidepressant. So you need to offer it, the patient, the antidepressant, give them the discussion around the risk of the antidepressants in pregnancy, and then document if they decline medication. The preference for treating severe MDD in pregnancy and postpartum is SSRIs, category C SSRIs. And those are category C medications are medications that you use in pregnancy, weighing up the risks versus the benefits. And then for the mom with severe MDD, especially with psychotic symptoms or intrusive self-harm thoughts, increasing suicidal ideation, ECT is the treatment of choice. But that's a specialist decision, and even from a psychiatrist like myself, if I have a severe MDD that presents with that picture, that cannot tolerate antidepressants or won't take it because they have irrational thoughts around it, we do the referral to the ECT program for them to consider outpatient ECT for them or inpatient ECT. It's really a very effective way to treat severe postpartum depression in these moms. All right, so the guidelines say that if there's a history of severe depression presenting with mild symptoms initially, you should start an SSRI. So remember I said that the moms who've had postpartum depression before or a depressive episode before have a 50% chance of having another one. So these are the moms that even if they present with mild symptoms in the pregnancy, you should consider starting an SSRI in them, because they're more likely than not to have worsening depression to get to severe depression. The best outcome for these moms is to offer them CBT and an antidepressant, So that means a referral to a CBT program or a repro program. And then some of them have, if they're still working, have EAP programs that they can do CBT with, and that might also be a quicker way for them to get CBT if you start them on an antidepressant. And of course, you as the family doctor can do CBT skills with them as part of your counseling. So that's also always an option for you to do the CBT yourself with them. We strongly recommend avoiding initiation of SSRIs after 20 weeks. Because generally there are more risks with late trimester initiation, and you should not initiate an SSRI for the first time in the last trimester of the pregnancy. There's a high incidence of pulmonary hypertension in the infant and other risks that can occur with premature labor, as well as neonatal adjustment syndrome, more severe than the mild one that can occur. So if you're going to start someone on SSRI, usually what I say is, let's say I see this mom who's had a history of severe depression, who has mild symptoms for that initial assessment. I have the discussion with them and say, I think you need an SSRI. And then I normally say to them, there's a window when we can start medication. This is the window. And I'm not going to be able to prescribe it to you after this window. So you have all of this time to think about it and come back to me on it. But we're not going to be able to start it later. And most moms prefer to have the detailed ultrasound done. And they want to have the neuroanatomy scan done and then say, okay, I'm going to start the medication because my baby is fine. So we do a lot of education about when baby's actually fully formed so that they can understand that, but it's still an uphill battle. There are a lot of hurdles that moms have to go through, and some of them actually happen at the pharmacy level. Once we get through this whole discussion, they end up at the pharmacy, and the pharmacist tells them you shouldn't be taking this medication, you're pregnant. So it's really sometimes an uphill battle to get them to comply with taking medication. So the other prescribing principle is all moms have of newborns, their babies have pulse oximetry at birth, because there's such a high incidence of moms that are on SSRIs. So 1/3 of moms whose babies have SSRIs, who have SSRIs, their babies have neonatal adjustment syndrome, or that poor adjustment syndrome when they are born, which means they're a little bit irritable, a little bit grumpy, don't latch that easily. So they have pulse oximetry at birth to monitor their oxygen levels and their tone, and they also have casual monitoring of weight and sedation for the first month post-delivery. That's a recommendation when you start someone on an SSRI.
Dr. Laban, there's a question in the chat just related to this slide. In broad strokes, do the respective effectiveness of medications, therapy, and ECT differ in pregnancy versus non-pregnancy?
Yes. So here's the first thing. The first thing is that in pregnancy, we can get away with much lower doses of medication than in a non-pregnant woman or non-puerperal woman. So for some reason, the SSRI, for example, the antidepressant dose, adult antidepressant dose for a major depressive episode in an adult is usually sertraline would be between 100 and 150 milligrams. You can have a mom who is depressed who responds to 25 to 50 milligrams of sertraline. We're not 100% sure why. It may be related to neurochemical change in the brain, a hormonal system that is very active, but they definitely require lower doses. They are also less sensitive to some side effects from SSRIs and more prone to other side effects from SSRIs. So I think that's the biggest difference we see. Patients with ECT in sort of the general adult major depressive disorder are usually given for different reasons, usually because they have like heightened suicidal ideation or refractory depression, like severe depression does not respond to multiple doses of antidepressants. And the third factor would be if they have like medical comorbidity that prevents them from taking sort of antidepressants that are going to impact them, and they have like catatonic symptoms, or they're not eating, or they're not drinking. So the ECT indications for people outside of the pregnancy postpartum period are very different from the ones that are within the postpartum period. And generally, the mom that is emotionally labile, highly suicidal, psychotic does the best with ECT, because it takes so long to get the medication to work within that sort of scenario, and it's hard to figure out the medication for them because they also floridly, emotionally labile, hypersensitive to antipsychotics during that period, and so it's difficult to manage them. So ECT does work better for them, but it's very different from what we would do for an adult patient outside. All right, so the antidepressants in pregnancy. So here's the perspective with regard to antidepressants and risk to a pregnancy, which is very useful for you to remember when you're having your discussions with moms. So we know that in the first trimester of pregnancy, there's lots of obstetric risk factors that lead to problems and spontaneous miscarriages. And so obstetric factors aside, the antidepressants convey a slightly higher risk of spontaneous miscarriages. So it is not that much higher than what occurs naturally in the general population, but it is higher by probably 1%. And then there's major malformations in 3% of moms who take antidepressants in pregnancy. That's also slightly higher than the moms people that are not actually on antidepressants. So in terms of category C, this is the discussion you have with those patients who are you wanting to prescribe a category C antidepressant to. And that would be most SSRIs except paroxetine, which is category D, and venlafaxine, Wellbutrin, all of them fall in category C, and some of the mood stabilizers also fall in category C. So they cause an increased risk of spontaneous miscarriages, preterm labor, and neonatal adjustment syndrome. It's just an increased risk. So what you're saying to them is, this stuff occurs in the general population at a certain percentage. There's a slightly higher percentage, a percentage more, when you are able to when you're on an antidepressant, and you give the mom the opportunity to decide whether she wants to take that additional risk. And because that risk is low, most moms actually consent to it. So that's the discussion to have, the simplest discussion to have when you're talking about an antidepressant, is saying there's a slightly higher risk. Spontaneous miscarriages occur in the general population. There's a slightly higher risk of 1% more if you take an antidepressant. There's a slightly higher risk you go into labor earlier. There's a slightly higher risk that your baby may not be that comfortable in the first 24, 48 hours after birth. 1/3 of moms who are on SSRIs, their babies will have poor adjustment syndromes. So category D, paroxetine is category D because it causes congenital heart defects. There's very strong association with it. So there's sufficient documentation, let's put it that, sufficient evidence in the database. And so if a patient who is already on paroxetine says to you, I want to stay on it, it's my best antidepressant, I tried everything else, nothing else works for me, my advice would be to refer the patient for a second opinion and get 2 doctors to give the patient that information. And I'm very frank with them, and I basically say to them, like, this is not something I can prescribe because there are other antidepressants that I believe can help you without exposing your baby to the risk of congenital heart defects in the first and second trimester of pregnancy. So let's consider a switch. But some moms who've taken paroxetine for years at 30 milligrams or 40 milligrams for panic disorder and depression, they've taken it for a very long time. They know discontinuation is a huge issue. They've tried other antidepressants and it hasn't worked. Some of them really dig their heels and then you just, if you have to end up prescribing it to them, they sign that they've had the discussion, they've waived the risk, and they're going to continue to take it. But my advice is always to get a second opinion. All right, time for the next question. Can you use doxepin to treat postpartum depression?
We have about half of respondents and the other half haven't decided yet.
Yeah, it's always a tough one.
All right, I'll end the poll.
Okay. All right. So, yeah, the 80% were correct. You can't use it to treat postpartum depression. So, doxepin can cause challenges in the newborn, but also in pregnancy can cause significant issues around birth, as well as there have been identified defects if it's used early in the pregnancy. We had a mom that was on very high doses at Maxine Wright of doxepin and did not want to agree to stop it, and none of us were prescribing to her. She was on a recurrent prescription of it, but at very high doses. And so when she delivered the baby had to be in NICU and went through some of the worst withdrawals we've seen in a neonate. And baby was in NICU for like 3.5 months, had seizures and was really challenged. So it's not a good drug at all. It's, even though it's a TCA, it's not a safe TCA to use in pregnant and postpartum moms. All right, so what are the TCAs that you can use in pregnancy? So tricyclics do cross the placental barrier, so they are a risk in a pregnancy, but they are low risk. So nortriptyline is probably the best tricyclic that you can use in pregnancy if a mom is responding to a tricyclic who has been on it before. It's better than amitriptyline, but amitriptyline is still also okay. They still carry the same 3 risks we talked about in the previous slide, which is the category C risks, which are higher incidence of spontaneous miscarriages, higher rate of preterm labor, higher rate of neonatal adjustment syndrome issues. Clomipramine, which is anafranol, you cannot use in pregnancy because it causes cardiovascular defects. And you will find some moms on clomipramine because they have OCD symptoms or they've had OCD for a long time. It's a very old OCD drug, but sometimes you'll get a mom on that and you should take them off it. There is evidence that there is third trimester withdrawal with TCAs, and it makes sense if you think about the neurochemistry of a TCA. So the tricyclic binds at histamine receptors, alpha receptors, serotonin receptors, so and cholinergic receptors. So there's a lot of receptor binding with the tricyclic, and so that's why there are withdrawal symptoms that occur with the baby. So our advice, because sertraline, for example, is such a safe SSRI in pregnancy and is effective for both anxiety and depression and at such low doses, that it's preferable not to initiate the tricyclic in pregnancy. If the person is already on a tricyclic, for example, for pain management or migraine management, and is taking 10 milligrams of nortriptyline and has been stable on it, you can discuss the risk benefits with them and you can continue the nortriptyline. But you should not initiate in pregnancy. So SSRIs in pregnancy. So sertraline is the SSRI with the lowest known risk. It has the least passage through the placental barrier. And so this is why we recommend it in most repro programs. But all SSRIs, including sertraline, if they initiated for the first time in the third trimester, will increase the risk of persistent pulmonary hypertension in a newborn. Paroxetine in pregnancy can do that after 20 weeks of pregnancy, not really even in the last trimester. So it's something to really be careful, be cautious about. And this is where also some of the miscommunication happens, because pharmacists will tell a mom, you can take the medication in the first 2 trimesters of pregnancy, but you need to stop in the last trimester of pregnancy because it's dangerous for your baby. And so they go into sort of antidepressant withdrawal or worsening of their depression in the last trimester. And it's because of this miscommunication. And then 1/3 of babies of mothers on SSRIs have poor neonatal adjustment syndrome. That's why we do pulse oximetry at birth. And then other specific antidepressants. So venlafaxine, which can be used in pregnancy, statistically has the highest number of birth defects, but the data is pretty limited, but it's still, like if compared to like sertraline and escitalopram, it's got a higher number of defects. Mirtazapine can be used in pregnancy. It's a dopamine agonist. It's not an SSRI, but there's limited data on it. Trintellix, which is the updated fluoxetine, has no data available. So it's really not something that we can sort of justify initiating in pregnancy. If someone is stable on Trintellix before, you can have the discussion and you can say to them, there's limited data. There are these other options we can switch you to, and the patient most likely will decline if they feel okay on Trintellix. You could also switch them from Trintellix to another SSRI. Usually escitalopram is a good choice, and then switch them back to Trintellix post-delivery. In earlier studies and in case reports, there have been these incidences of specific defects in pregnancy that are really blown up sometimes on social media, but it really is infrequent, and there is no indication that it's a higher incidence than in the general population. So in other words, it's more like an incidental case report finding than that the medication is associated with it. So there have been case reports where someone is on citalopram and baby has a diaphragmatic hernia, but there's no higher incidence than what would occur than how often diaphragmatic hernias occur in the general population. The same for fluoxetine. There have been some studies that talk about anomalous pulmonary venous return, but it's not anything that's been documented in large enough numbers for there to be any concern around fluoxetine. But because of that, some people prefer not to use fluoxetine in pregnancy. And then paroxetine has the highest evidence for congenital heart defects. So there have been early studies, isolated cases. Most of them have very poor study designs that SSRIs or TCAs have been associated with a high incidence of preeclampsia and perinatal death. But the truth is that preeclampsia, the highest risk is a primiparous patient, so first-time pregnancy, and other risk factors are far higher than being on an antidepressant. In fact, being on an antidepressant, we know, reduces the risk of pregnancy-related hypertension.
Dr. Laban, there's a question here before we go to the poll. Does it mean that it's okay to start an SSRI from the beginning of the pregnancy and continue it until the end, but not to start after 20 weeks?
So yes, that's exactly what it means. It means you can start in the first or second trimester. You should avoid starting after 20 weeks, but you can if a mom gets severely depressed, but you should not initiate after 28 weeks for the first time. So you can't start it for the first time. So if a mom has taken antidepressants before, you can start early in the pregnancy, but you can also start first time round in the first or second trimester. But most moms tend to say, I'm going to wait to see the the neuroanatomy scan. You can always ask for them to do the scan earlier than 20 weeks. Some moms get it done at 16 or 18 weeks, then you can start an antidepressant earlier. So we recommend avoiding it, after 20 weeks, but you can still start it, but definitely not after 28 weeks.
And then there's another question, is duloxetine okay for pregnancy?
Yeah, I was going to talk about duloxetine. So duloxetine has limited data in pregnancy. Duloxetine is Cymbalta, so it's the advance on fluoxetine in the sense that it also helps with pain management. It is used in pregnancy. It has similar risks to the category C antidepressants. So it's just that it has far less data than sertraline and escitalopram. So if someone's depression is controlled on Cymbalta, the advice is to consider lowering the dose. So usually by the time someone's depression is responding to duloxetine, they're on 120 milligrams a day. Our recommendation would be to reduce that risk of spontaneous miscarriage in the first trimester, and especially of preterm labor. We recommend dropping that dose to 60 milligrams versus keeping it at 120. So that might be the better option than switching them to another antidepressant, because you won't get control of pain-related symptoms usually with another antidepressant. Cymbalta is not recommended for breastfeeding though. There's limited data, but it's not the best for breastfeeding. So it's a discussion to have with the mom during the pregnancy to say, we can start you on an antidepressant. Cymbalta might work for you, but you may not be able to breastfeed. There are some ways around it. Some of our moms have said, no, they want to breastfeed, they want to stay on Cymbalta. And so for them, we use the technique of pump and dump. So basically what happens is they take the whole dose of Cymbalta in one go. They breastfeed in the day, they pump in the day, they breastfeed their baby, give them the dose of Cymbalta, use the pumped milk for the next few feeds, and then go back to breastfeeding in the morning. To kind of reduce the issue with breastfeeding and Cymbalta. So some of our moms have done that when they've insisted on taking it. Because remember, all of these moms, when I say they've insisted on taking it, all of these moms are voluntary patients. They're not certified patients. So they have to give you consent for anything. So you can give them information and they can insist, no, I don't want to do this, or I want to do this, or this is what I want to do. And so you document the discussion and they voluntary. And so especially with severe depressed patients, you can't make the judgment of saying, okay, I'm going to stop. I'm not going to give you anything. If you don't want to take this, I'm not going to give you the paroxetine, or I'm not going to give you the Cymbalta, because then there's going to be a risk from them being depressed, right? And possibly harming themselves with baby. So it's kind of weighing up that catch-22 and finding a middle ground with the patient.
And then
all right, antidepressants for postpartum depression should be stopped 1 to 2 months after remission of symptoms. And I'm sure most of you get pressure about that from your patients, or their husbands.
While they're answering the polls, Dr. Laban, there was another question in the chat. Did you want me to ask it now, or did you want me to hang tight?
Let's just do the poll and then we can give it some attention.
Sounds good.
Yeah, I don't want to lose everyone's concentration, because I think the questions are the best way we learn.
This one, lots of people answered right away. There's 31 already.
Yeah, this is a really good family doctor population. Yeah.
Here we go.
Absolutely great to hear. As a psychiatrist, this makes my heart very glad. So yes, because actually many years ago they did these studies on fluoxetine, like relapse prevention studies, which showed that you should start to think about reducing or tapering antidepressants 6 months after remission of symptoms, bare minimum. So you shouldn't do it 1 to 2 months after remission of symptoms. And so it's the same for the postpartum major depressive patient. It's the same principle, because we know that 60% of patients, even on antidepressants, will relapse and have a recurrent episode if it's a major depression. And so you're giving them the best possible chance. So what you're doing actually at 6 months post remission of symptoms is you offering them a challenge. So when you're doing the taper, if you start to get resurgence of the depressive symptoms, it's an indication you need to treat the patient for longer. And generally, the rule of thumb is 1 episode, treat for 6 months, challenge. If symptoms come back, take it up to a year. If symptoms don't come back, continue the taper. If they've had more than 1 episode, you do that for 2 to 5 years. That kind of situation that they have. If they've had more than 2 to 3 episodes of severe major depression, it's treatment for a much longer period on an antidepressant. So this is a relapse prevention question, is to prevent them having a recurrence. All right, so postpartum depression. How do you get a mom to tell you that she is depressed when she comes to you for the 4 or 6 week visit? Because this is the guilt that the mom has. And remember, when they come to you at the 6 week visit, they've just gone through the delivery, possible recovery from C-section, trying to navigate breastfeeding, are sleep deprived, they're feeling really, really, negative. So one of the tricks that we use in psychiatry is that in a medically ill patient, and the postpartum mom fits that category because they sleep deprived, they're not eating, they don't have energy, they're fatigued, and they can't think clearly, and they don't have time to prepare food or self-care. In those moms, it's very hard to know about the criteria for MDD. You have the first 2 criteria, then you have to have all these other ones, which are like sleep changes, appetite changes, energy changes, guilt, all of those things that sort of support the major depressive episode. So how do you diagnose that in a medically ill patient who is tired, fatigued, not sleeping, not eating, losing weight from their medical illness? It's the same with the postpartum mom. And so the way to do that is to look at Beck's, the guy that did the Beck Depression Inventory Scale. So Beck's cognitive theory of depression, which is at the triad, which is the negative view of self, negative view of the world, negative view of the future. So if this mom is sitting in front of you and she is saying, I am useless, I'm hopeless, I'm a failure, that's a negative view of self. I am worried about my baby. I can't see how my baby is going to be okay in this world. There's so much happening out there. There's uncertainty out there. And I don't know if I'm going to be a good mom and I'm going to be able to take care of this baby. How am I going to cope when I go back to work? How am I going to cope when the baby goes to school? How am I going to cope with my toddler? That's a negative view of self, world, and the future that mom has a postnatal depression, no matter what else she looks like in front of you. All right, so this case is the second case, which is a postpartum depressed mom that I saw. Tammy actually saw this patient with me, so this was really a very interesting case. It was a complicated pregnancy. Patient had HELLP syndrome at 27 weeks and delivered baby, ended up with a NICU baby. She was a very high-functioning mom. Is actually a chartered accountant, and the dad was also high functioning. He's a software engineer. They were US based and then moved to Canada, but they actually a South Indian family. And there was extended family involvement. So his parents were here and her mom was here. And this mom had significant amount of guilt about the fact that she had HELLP syndrome and that her baby was born at 27 weeks. The baby's fine, the baby survived, the baby's now doing really, really well. The baby's about 3 months corrected age. But this mom became severely depressed. But because of her personality and because she was so high functioning, she was totally irrational and just refusing any sort of help, very negative and blaming and critical of sort of Canadian healthcare system. If she was in India, she would have this would never have happened to her. She wouldn't have had the HELLP syndrome. The care is better there. She had to wait for all of these tests. People didn't know what they were doing, kind of thing. She went on and on about that for quite a long time, but was going to the NICU every day and making sure that she was feeding the baby and breastfeeding the baby, but totally detached from the baby. And when we first saw her, she wouldn't engage in terms of accepting that she had a postpartum depression. Her husband was extremely worried about what she was saying all of the time. And we got her through that initial NICU period, just by sort of frequent contact with her. We still couldn't get her onto an antidepressant because her engagement was just very challenging. And then the baby started to get better, and she would research these statistics as to what was going to be happening to the baby. And she would want a guarantee from me that this baby would not have neurological issues, baby wouldn't have like blindness, baby wouldn't have, deafness, and she would be pestering the neonatologist for those kind of statistics herself because she wanted that guarantee, or she felt she wouldn't live. She was constantly saying she wants to die, she's going to kill herself, she's not going to live. If they tell her a baby cannot hear, she's going to die. But still kind of refusing, any engagement or wanting to take medication. I said, I'm going to certify her if she doesn't take medication. And so she eventually agreed to escitalopram, and we started on that. And slowly some of that started to shift. Her mood started to shift. Then baby came home. This little daughter had survived from 27 weeks to like 40 weeks. Well, they actually discharged her at 38 weeks and came home. And this mom says to me, I need some time. I need some self-care. I never got that in my pregnancy because I never got pampered. This was my first baby. I'm going to go to India to go to a spa. I can't even tell you what happened to me that day because I just was so overwhelmed with my own sort of countertransference about how this mom could do this with this baby. And, and I remember calling Tammy because I was so upset. In fact, I was talking so loudly, my daughters who were in the other room thought I was kind of yelling at somebody. I was yelling at a patient because I was so overwhelmed by what she said in that interview with me, because there was such, I thought, self-absorption, around this. And I didn't understand just how much the guilt had kind of caused her to be so irrational. We just kept upping the antidepressant, got to 20 milligrams. And the husband kept saying, we cannot take the baby to India. There's pollution. We're going to have to wait for the neonatologist to kind of like clear the baby. So we just kind of pushed it until the depression lifted. And then it was like a switch, a complete switch. She went back to being the person that she was before she fell pregnant, was engaging with the baby, very positive about the baby, positively engaging with me every 2 or 3 weeks. And her depression had lifted. And this case showed me clearly just how severely postpartum depression can alter the picture for a mom, and how challenging the guilt can be in causing their sort of behavioral change. So her desire to be away from the baby was not about her not wanting to care for her baby. She loved her baby. She just could not get over the guilt of having HELP syndrome and having the baby be delivered early. She felt she let her baby down. So I wanted to say that even me as a psychiatrist gets overwhelmed by these cases of postpartum depression. And I've been doing this for more than 5 years now, and we see so many depressed moms, but every now and again we'll get a mom that's this severe that really challenges like our management. So here are the latest guidelines, the NICE guidelines for, they were done in 2021, which we kind of have to follow now. And so basically we've talked about it already. So if they have persistent subthreshold depression, mild to moderate, you can do CBT. If they have history of severe depression and they're presenting with mild symptoms, you should offer them an SSRI, but they don't have to take it. If they have moderate to severe depression, SSRI and CBT. If they become pregnant on a TCA, SSRI and SNR. RI and they have mild to moderate depression, you can offer them a taper, especially if they want that. And you can stop it, but you should offer them CBT. So if they don't want it and they have mild to moderate depression, you can offer them a taper and just document that the patient did not want to continue the medication. Just remember with SNRIs, you have to go really, really slowly because they give you discontinuation syndrome in the taper. So if they're pregnant and they have moderate to severe depression and they want to stop, you cannot just kind of heed what they're saying. You're going to have to go over and over the discussion with them about the risk to the baby, the risk to themselves, offer them a switch to something like sertraline and add CBT, and continue to engage this mom in trying to prevent a severe postpartum depression. And in terms of the NICE guidelines, like breastfeeding, all meds pass into the breast milk in small amounts. So they trace amounts, and sertraline is the most studied one. So that's why it's the most recommended in breastfeeding. So antidepressants and breastfeeding. So the only way to actually know what's happening with breastfeeding is to monitor infant plasma levels. And obviously we don't do that, right? But they have pooled studies in which they've done that. And basically this most number of infants they got into those studies were 200. And they found that nortriptyline, paroxetine, and sertraline levels were undetectable when you did infant plasma levels. So it stands to reason that those are the best in terms of breastfeeding. And there's the conundrum. Paroxetine you can't use in pregnancy because it causes congenital heart defects, but you can breastfeed on it because it's not in your breast milk. So it's just a conundrum, right? Fluoxetine, citalopram, and desvenlafaxine, which is the metabolite of venlafaxine, has low measurable levels. So they also okay for breastfeeding. They have found that there's irritability, decreased feeding, and sleep problems in infants in the first few weeks after delivery if they were exposed to antidepressants. And that's why we ask for casual monitoring of sedation and weight gain in babies in the first trimester, in the first month after delivery. So if you've had a good treatment response already for a major depression and in the pregnancy or a previous postpartum depression, our recommendation is not to switch the antidepressant, because if someone's responded to something before, or if their mother has had postpartum depression and responded to that medication before, it's most likely the one that's going to best treat their depression. So what we're saying is most of these drugs in category 6, in category C, expose them to these kind of risks, right? The risks are pretty similar. So if they're responding to a particular antidepressant, then rather not switch them or rather not taper them, because the risks are the same, despite the antidepressant, generally, okay? So what are your factors in terms you have to consider when you're wanting to start treatment? The previous treatment response, like what antidepressants they responded to in the previous episodes of depression, their stage of pregnancy, and we've talked about that. You can't start in the last trimester. The risk of them relapsing. So let's say they're already on an antidepressant, they have a previous history of hypomanic episodes postpartum, they're now on an antidepressant and they're stable. The likelihood of relapsing is pretty high postpartum if they're not on medication. Then the risk associated with the medication specifically and the patient's preference. So when you have that discussion with the patient and give them all the information, you should document this was the patient's preference. They chose to take sertraline, they declined escitalopram, they heard a negative thing about fluoxetine, they didn't want to try it. They want to stay on Cymbalta because it helps them with the pain. So you document that, right? And then with an SNRI like venlafaxine, if you taper the dose slowly in the first and second trimester, you will reduce the severity of the neonatal adjustment syndrome. So obviously, because venlafaxine has discontinuation syndrome in an adult anyway, with the newborn, if a mom's taking it at higher doses, they're going to have most more likely than not, a moderate to severe neonatal adjustment syndrome. And that means the baby is tremulous and, twitching and not feeding and not latching. And it's quite scary for a mom to look at a baby that's trembling. So what we normally say to a mom, let's just say they're on 225 milligrams of venlafaxine when they start the pregnancy. You can say, let's slowly go down by 37.5 milligrams, see how you do. Let's get you down as close as possible to 150 milligrams or even 75 milligrams before you deliver the baby, and then we'll go up again. But the problem with venlafaxine is it does have discontinuation. So if you're going to do a taper, you need to do it very slowly. So no sudden changes, like you can't go 225 and then less by 37.5 every week. That's not going to do it. They're going to have they will have a full-blown discontinuation syndrome with panic attacks. So you'd have to go pretty slowly. So let's say they're on 225 in the first trimester. You'd say, let's start you off with less 37.5. I can never do the math. And then you then say, okay, we'll see you again in the second trimester in about 6 or 8 weeks. Let's see how you're doing. If you're doing any better, let's go down to 150. And then we can review this, when you get to the last trimester, and then say, okay, do you want to consider going down or do you want to stay? Sometimes they choose to stay. Sometimes they go do 75 and 37.5. So whatever that adds up to, you can give them that, so it just reduces that severity of the neonatal adjustment syndrome. So SSRI withdrawal can occur in a third of cases. So you have to have a discussion with the obstetrician or neonatologist who's delivering the baby. It's a very important discussion to have. Although the FBU has a standing order on the FBU charts to say that these babies need to have pulse oximetry and monitoring because of they're on an SSRI. So it's actually written on red on the chart if someone's on an SSRI or an SNRI. And the last point is that any patient that's on an SSRI should have an ECG at some point, especially escitalopram. And if you have someone on escitalopram who's pregnant, my advice is to do just a standard ECG. There's no rush to do it, so that you get that corrected QTC value, because the prolongation of QTC is not a problem with escitalopram per se. But this is a mom that's going to go into labor, going to get anesthetics, analgesics, antibiotics that can also cause prolongation. So the anesthetist needs to know what the value of the QTC was on escitalopram prior to labor. And so it's always helpful for you to have that baseline done for yourself. It also helps you then if you're going to add for yourself pain medication or antibiotics for a patient, or if you want to give them domperidone, or if you want to add quetiapine or something like that, you need to know what that QTC level is. So it's helpful to send them for an ECG. All right, I just wanted to talk a little bit about cannabis because I know there's a lot of pressure on family doctors about cannabis. There's absence of data on safety and long-term effects on infants exposed. That's your standard line to your patient who says that to you. They should avoid or reduce as much as possible if abstinence is not feasible. And we encourage you motivational interviewing every time you see them to consider stopping cannabis. Because there is definite evidence that there's low birth rate in cannabis babies. All right, time for a question or a break. Obsessions in postpartum depression are twice as common than in non-puerperal major depression. True or false?
Seems like most respondents are pretty confident in their answer.
I can see that. Yeah, and they're right. They're completely right. And that's what they're probably seen in practice, right? Is these moms have obsessive thinking, they have obsessive loops of thinking, they change, they have intrusive thoughts, although those are not really obsessions because they they're more kind of being created by the brain chemistry. These are not moms that these vivid imageries that they get, or these intrusive thoughts where things are falling down, or babies getting hurt in some way, or they look at a knife that's coming out of the dishwasher and think I'm going to stab somebody with it. Those are not moms that are having obsessional thinking. They're just having sort of intrusive thoughts. But the generalized anxiety mom is the mom that has these loops. And usually the obsession is around, like, for example, if they're anxious in the first trimester because they've had like miscarriages before, then it's going to be, okay, I need to check baby's heart rate. Then I got to have multiple ultrasounds. Then I've got to listen to get a fetal heart monitor going. I want to be able to listen to baby's heart rate. And then it's the multiple checking of kicks, and then it's going on the internet and researching and stuff like that. So this is pretty common in this mom versus, someone who has normal major depression, although the incidence of panic attacks in both are the same. So postpartum and normal major depression, there's a high incidence. All right, so now we're looking for case discussions. Or questions, more questions.
There was one question that was still left in the chat, and you started to answer a little bit. It was, if a patient is on paroxetine, can we continue paroxetine? And if yes, do we need to do any specific investigations due to cardiac risk?
So, I think the question is the question is whether you should continue it. My feeling is you should ask for a second opinion, usually from a repro psychiatrist, to have that discussion with the patient. And if the patient still wants to continue the paroxetine, they need to kind of sign a waiver, basically. They sign a form saying they've been told that there's increased risk and they still want to use it. And then you could have them seen by ask for like the ultrasound to be done sort of earlier, the detailed anatomy scan to be done earlier, to check do the cardiac check earlier on, because the initial ultrasounds don't actually do the cardiac check. And it's usually conduction defects that are not very easily picked up on the earlier ultrasounds. And so it's also then kind of liaising. That's a patient that I would also say maybe you need to see an obstetrician or get seen earlier for your ultrasound. And if it's an all clear, then it's okay. I would definitely also say talk to the patient about maybe reducing the dose until they can get the scan saying that everything's okay.
We are a couple of minutes past time, but I also want to give people the opportunity to either bring some more questions to Dr. Laban, or if you have brought a specific case with you that you would like to discuss this evening, we want to give you the opportunity to have that conversation. So if you're able to stay and chat a little longer, please raise your hand and you can ask your question. Actually, I'll just pause there. So if you have a specific case or a specific question for Dr. Laban, please feel free to raise your hand from the chat or pop it into the chat box.
So while that's happening, I just wanted Tammy to just talk to doctors about our program and how to refer and what we offer.
Hi. So we have our standard referral form, which I'm sure many of you are aware of. All referrals are triaged the same day we receive them. So they're looked at and for anything that we deem urgent. As Dr. Laban had mentioned, everyone is seen initially by psychiatry for an assessment. And then from there, they can be referred to our groups and if needed for individual counseling. So there's myself, I'm a psychiatric nurse, and then we have a registered clinical counselor. So the two of us do individual and group counseling. For our groups, we've got our skills group that runs every Wednesday for an hour, and it's being done by Zoom. We switched over to Zoom, obviously at the start of the pandemic, but we've ended up keeping it that way because it actually reduced a lot of barriers for a lot of our clients who, for whatever reason, we've literally had women on bed rest attend group. So it's been actually attended even more so now. So there's 10 modules in that curriculum that just repeat. The only time we don't have groups the week of Christmas and New Year's. And the topics include, the basic self-care. We use the NEST model, which is nutrition, exercise, sleep, time for self, and support, which is used a lot through reproductive mental health as a preventative technique. And we do a lot of teaching around that. We also have basic CBT, mindfulness, that sort of thing that's included. We also have the closed CBT group, CBT for perinatal depression, that we run a few times a year. And that's based off of the Mind Over Mood book by Christine Podesky. And there's actually 2 additional sessions that we do, 2 evening sessions for partners. So one session just for partners with psychoeducation around, perinatal depression and anxiety and support for them. And then a session at the end that's joint with the women and their partners together to work on things like communication, conflict resolution, that sort of thing. So that's been a really great group to do.
Thank you, Tammy. There's a question here in the chat for you, Dr. Laban, about moderate versus severe depression for initiation of SSRI and CBT. In addition to the reported symptoms, what tool, i.e. the PHQ-9 or the GAD-7, is used?
So, yeah, we don't, so, it's not, so the PHQ-9 is a good indication of severity of depression for you, but I think if you've known this patient before and you see a change in the intensity of the depression, that's one way of knowing what to do. The second is if there's escalation of intrusive thoughts, self-harm thoughts, associated panic attacks, that's also another indication of severity. But the PHQ-9 is a really good way of doing it. The only issue with the PHQ-9 is it's a self-rating scale. And so sometimes if there's sort of relationship stuff happening or the patient's emotionally labor from a situational crisis, sometimes it can score higher. And so your mental state examination is always your go-to to determine severity of depression. So the depressed affect can be scored as objectively as hypertension. And I can hear the laughter in the family doctors' minds when I say that, because everyone thinks like, psychiatry is like sucking your thumb and saying this person is depressed. That's not true. So, so when you assess affect, for example, there's 5 ways to do that. That says that this person's got a depressed affect. The simplest way is to say, do they make eye contact, use gestures like how I've been doing all the time, change in facial expression throughout the interview, tone of voice, and so and posture of the patient. So if you score all of that, you will see that this person has got severe depression or not, just in terms of their affect. Then they have attention and concentration issues, cognitive issues, memory issues, and then all of your sleep stuff and all of that. So I think you are able to see the severe depression more clearly than the moderate, but I think the moderate is easier if you know them and you know that it's worsened. But otherwise, just use the PHQ-9 as a rating. The EPDS is also it's a good one to do for postpartum depression, but its only significance really for us is if 10 is ticked and there is like some form of self-harm or thoughts happening, then that's more likely an indicator of a severity of a depression.
That's all for the chat questions, and I didn't see any hands raised. We have a hand raised by Sheena Goldie. Go ahead, Sheena.
Oh, hi. I just had a question about multiple medications for some of our patients. I have someone right now who I got 20 weeks pregnant, and I've sent her to you guys for an opinion, but she's, she is on Cipralex and Wellbutrin and also amitriptyline. And I just wondered if there was any comment on these patients that come to us with multiple medications, and whether you look at them just individually or whether there's any concerns about having someone on all three medications.
Thanks, Sheena. That's a very, very good question. So, if just listening to that tells me that this is someone who's already had sort of depression for a while and medications have been added because she's not been responding to one. So I think, so you're dealing with someone already in the moderate to severe category. The thing with these antidepressants together is it is cumulative risk. And so what happens is the discussion that you have with them is to say, okay, of these three medications, when were they started? Which one helps you the most? And then it depends also on the doses, because sometimes if they're taking like 10 milligrams of amitriptyline for pain or something, and 25, it's an easier one to sort of discontinue. And then you look at sort of Wellbutrin and sort of escitalopram, and you ask the patient, like, were you taking escitalopram for a long time, and was Wellbutrin added for energy? Is that the newer one? Which one you felt was effective? And then what you normally do is, in that sort of situation, I would say to the patient, like, amitriptyline is something that we can withdraw with the least amount of issues, especially if it's a low dose. If it's a high dose, there's going to be withdrawal. But if it's a low dose, you sort of withdraw it. And then between the two, escitalopram and Wellbutrin, if you see them in the first trimester of pregnancy, I would say to them, this is a cumulative risk to, like, the risk of spontaneous miscarriages in the first trimester. So what we do here is we hold Wellbutrin, we continue with escitalopram at its dose or slightly lower. Usually they come to you when they're like 8 or 10 weeks pregnant already, or around that time. You just need to get to 14 weeks when this risk is no longer an issue. And if your mood worsens, we go back on the Wellbutrin. That's what I normally would say to them. I hope that helps.
Yes, thank you.
Yeah. Anyone else got any questions about a case? So I wanted to say to all of you, I'll even say myself out loud. It's 778-837-5799. I'll put it in the chat. You can text me at any time, call me at any time if you've got a patient that you're worried about, or you want a question on medication management, or you can phone the Repro program and just tell them you need to speak to a psychiatrist. There's 4 of us in the program, and we will call you back and discuss the case with you if you can't get your patient in quicker. We've really tried in our program, especially the Surrey one, to get a good turnover. This is why Tammy and them do the triage. And so if we can identify from the forms this person needs to be seen earlier, we try to do that. But if you're worried and you feel like, okay, it's been a while and I haven't heard anything, then just call us and we'll be able to sort of give you an opinion on what to do with medication. The other thing is that I have asked the pharmacist who is at UBC, who is the expert on medications in pregnancy, to prepare videos for you guys. She's going to do them and send them to April once they've been edited to be sent to you. So she will be doing almost like a reference sort of videos clip for you with different videos on each of the medications with clear guidelines and sort of pharmaceutical information around it. She'll also be doing a video on informed consent and about domperidone and antidepressants, because that is something that always gets into like big issues, with QTC involvement. So she's going to do those videos for us. She's the expert on it. When she was at Surrey Memorial, we used to call her if we had wanted an opinion. Neonatologists call her from the NICU if they wanted an opinion. So she's the best person to do this. And so we will get her to
We do have We do have another question, but before I get to that question, Dr. Laban, just for the rest of you who are on the call, there is an evaluation form the link is posted in the chat for you. It should only take you a minute or two to complete. Once you've completed the evaluation form, your CME credits will be sent out to you. The certificate will be sent to you. And like Dr. Laban had said, in terms of what kind of follow-up clinical support material you can expect to receive in the next couple of days, we will be sending out the PowerPoint presentation. There will also be the recording from this particular session will be posted to the Surrey-North Delta YouTube channel, and we'll send out the link for that. And then there will be a number of videos that Dr. Laban was referring to coming to you in two different segments, some in the next couple of days, and then a couple more about the prescribing pieces over the next couple of weeks. We don't want to inundate you with too much information, but we certainly want it to continue to be relevant for you. So I know Dr. Laban was going to put her contact information in the chat, which is great. Please take a moment to fill out the evaluation. And in the meantime, I'll continue to read out the questions.
So Tammy, can you enter my number into the chat?
And Dr. Laban, one of the other questions, so is there any specific investigation or precaution for patient with history of PPD in a previous pregnancy, now on sertraline and preeclampsia in previous pregnancy?
So it depends on the dose of sertraline, but I would do sort of ECG. You'd also just double check TSH and sort of their CBC because both of those things can contribute to depression. And if you don't have the details of the previous PPD, then you don't know if those factors were there, because sometimes it's physiological. Sometimes with sertraline, it's worthwhile sort of just doing some of their sort of liver function if they've taken it for a long time. And yeah, but the QTC is the biggest one to do at an investigation level. Yeah.
Let's just see.
Dr. Laban, did you want to mention about the race app or the race line?
Oh yes. So we were just having this discussion to say that if you're not able to get through to the you should be able to get to our repro program. Let's put it that way. You definitely should. But if not, the race line is available to family doctors. Dr. Anna Nazif is at Burnaby, and she's on the race line. She's a psychiatrist, and she also has an interest in repro. So if you are if you're not able to and you want to get a psychiatric opinion, please call the race line. It's a Doctors of BC initiative, shared care initiative that helps family doctors connect with a specialist in the moment and just get an opinion. It's a short call. They'll just tell you yes or no to a medication, that kind of thing. And you both can bill for it because you just use the patient's PHN because it's an advice on the race line. There are plans in Fraser Health to expand the race line now to all of the different areas, because there has not really been a focus on advertising the race line in Fraser, but there's a plan to do that to help family doctors.
So I just want to, looks like the chat's sort of quieted down a little bit. I just wanted to say a big thank you to you, Dr. Laban, for coming out and sharing this fantastic knowledge with our family physicians. We're so grateful for it. For the family physicians who have joined us this evening, thank you, as always, for giving us your time. We are very, very grateful for it. I know how busy you all are. Tammy, thank you for joining us and offering your knowledge to us as well. It was a pleasure to meet you. For the physicians on the line, if you want to continue to just wrap up the evaluations, as we mentioned just a couple of minutes ago, we're going to send out some clinical resources for you along with the PowerPoint presentation and the link to the YouTube video, both from this evening, as well as some clinical supports in the coming days. So please watch out for those things. If you find that you do not receive those clinical resources, please just reach out to myself. My name is April. Most of you know who I am, or Jody, of course. Most of you know who Jody is as well. or any member of your PES team, any one of us can help you get the clinical resources that you need from tonight's session. So once again, thank you very much, Dr. Laban. We appreciate your time and hope you all have a wonderful rest of your evening.
Yes, and I also want to say to everyone listening, thanks for bearing with me. And sometimes these things can be really tough to listen through. And I hope that there's something that you're able to take away from it. And I really meant that when I said call us at the program. I'm more than willing to be able to chat to you about your cases. I'm a South African by birth, and that's how we did it in the old country. Let's put it that way. So we would just call each other and just say, "What do you want to do about this patient?" "Oh, I got this patient. What do you do?" And I'm so used to that. I miss that. So really, I really mean it when I say call the program and talk to me. Thank you so much.
Jody's bumped your phone number to the bottom of the chat there so everybody can see it. Yeah, it's right there for you.
Okay. Thank you.
Thank you so much, everyone. Once you're done the evaluation, please feel free to head off for the rest of your evening. Thanks so much, everyone.
Dr. Laban, there's